Oh, it says recording.
Yep. I have to share the audio and the video as well.
Great, thank you. We also
And then screen share.
cool. Thank you.
Yep.
Can we see the camera?
We should be able to turn the fire up.
Perfect.
Are you setting it up?
We're just making sure the video's on you all. And I'm just gonna. Are there windows I can close? I don't want to mess with things.
Okay. I don't. Best thing is just to bring the presentation up and then leave the others kind of minimized.
Okay. Is there any like the Zoom stuff if people need to do anything like so this is the presentation. This.
There you go.
Cool.
But if you can either take a hand, clear out. Good guys. Nope. Everything's all set. We said number two. Sounds good. Yes. Call the walls. Okay. If you get back here. Yeah. I bet. I'm gonna film it, but you got it. There you go. Well, you're I think the well, then aren't we firing but you heard everything will go? Yep. We just have to advance that doesn't go. Order some song. You could only that. How's the home? Right. Eddie. Immigrant. Okay, yep.
I Gary can hear. Yeah, clear. Do you have slides or no? Yes, but I like emailed it to the Health Equity Summit
When did you do that?
like last week.
Because you're going second.
Yeah.
Is it this?
Yes.
Perfect. Then great. We'll pull that up
Okay.
after. So this is already being shared. Your mic is live. Then it's recording. You'll be able to start on time.
You're the best.
Got it.
How do I switch between?
Huh?
How do I switch between?
How do you switch to one?
Between to the next one? No. To the next presentation.
Oh, what do you like say? Out. And then you'll see it on the bottom. It literally has a 2 next to it, and then you'll go to slideshow. I'll come back at 30.
Thank you.
You're welcome. Oh. You Thanks for your own.
All right. Good afternoon, everyone. Nice to see you. So I'm Katie Wells. First, I'd like to say I'm an ally, I'm an advocate. I also happen to be an ER physician and the director of social medicine at the College of Medicine, a couple other roles. But I want to say this is really my distinct pleasure to be here to introduce this crew because the people that you're going to get to hear from in the next hour really are transforming and have been for a long time care of our immigrant, refugee, and migrant population. I don't have to tell anyone that right now is a really tough political climate for these folks. There's been a lived experience and a trauma that this group of individuals, and we don't want to do a broad brush that all of these folks have the same lived experience because they don't. But what we want to do is advocate for why health equity with this patient population is so important. And when we talk about equity and we talk about equitable care, we have to also remember that the type of care that we deliver cannot be the same for everyone. And we have to take into account that lived experience and that cultural contextuality. And so with that, I really want to turn this over to this amazing group of people. So we're going to start with talking about the Immigrant Health Initiative Year 1. And we're also going to talk about lessons learned from immigrant and migrant outreach. And so navigating the health system for health equity. I'm going to let everyone introduce themselves. But just to kind of mention quickly, Dr. Ben Clements, who is not able to be here, family medicine, he is in clinic, and we'll talk a bit about him. Claire Baptiste, one of our incredible College of Medicine students, who just finished a big exam and I think did really well. Sarah Stinnett, who works with the Family Room and Building Strong Families Clinic. Naomi Walcott-McCausland, who works with UVM Bridges to Health. Casey Collier, who is one of our Global Health Equity Fellows, who also has been working on this project. Mohammed Jafar, which you'll hear more from. Vicki Mascarino Nelson, who you also hear more from. Ash McCormick, who is also one of our other Global Health Equity Fellows. And myself. And so we're really happy to get to speak with you about this today. How the session is going to run is we're going to go through both presentations and then we'll take questions in the last 15 minutes. So please don't leave early. We would love to hear your questions and your thoughts and your ideas and your personal stories of how you've interacted or interfaced with folks from these communities. So with that, I will turn it over to Mohammed Jafar and Vicki Mascarino Nelson.
That one working.
It is. There it is. First of all, thank you all for being here. My name is Mohammed Jafar. Should I just introduce myself in the hand? Am I going in here?
Go on in.
All right, all right, all right. My name is Mohammed Jafar. As I just showed, I am the Immigrant Health Project Coordinator for Young Medical Center. What does that mean? What does that entail? It touches on all things immigrant and refugee health. In other words, that we look to expand accessibility for immigrants and refugees, and also just when we had care. And the first has been it's been difficult, encouraging, and successful in a lot of ways. And that is how I would describe the first year. But before I go into that, if there's anything that I would like for you all to take away from this discussion and that I will share about my word is just the criticality of curiosity and ensuring that we're really leaning into allowing community members to use out what healthcare looks like for them. And I will share with you a few projects that I've been working on over the year. And I want to be very clear about stating that these projects are obviously came up with their own mind ideas. I didn't do it myself. The community plays a tremendously large role in telling you what to do, and telling you the support them how to make this work truly exist to support them. The first project that I will share with you is the Chelsea project and end of this project. And actually, before I go into that, sorry, I would actually like to share a little bit more about the role and the way it's created. This role was specific and unique in the way it was designed. And the job description was created with community members. So before I even came on, as long as I existed, this job was created from the health needs assessment, and the community said we need an individual we can pretty much yell at and tell and share all about concerns too. So that's how the role was created. The role was also unique and was set up. It was not your typical channels. The sites with HR and ensuring that the role would be provided not sites, but you know what I mean, ensuring that the rights that the individual rights to be out. This role also had for the family applicants the roles of the different one that we did the recruiter screen those folks. We have supervisor maybe supervising screen every individual that could potentially get the role. There are 8 individuals that are brought in for interviews. Incredibly unique them a life experience is second to none. So the this role, I really want to just say that the benefits that interviewed for this role are incredibly sensitive and incredibly talented individuals who also have taken this role. So I got, and I was the chosen one. I'm humbled at knowing that the process gave me a lot of incredible candidates. So first and foremost, those accolades to my supervisor, Mr. And Armstrong, and this is our leadership for designing similar in partnership with the community. So this was not, this is what we think needs to be done in the res after that was spearheaded and led by community members. With that said, I will jump into the projects that I'm working on. The first project that I'm working on is this autopsy on end of life project. And is this project, you would ask? This project is aimed at ensuring that our community members are fully, especially after the COVID pandemic, right? A lot of families that those members were feeling as though the health needs. Second, when you really think about something that could pandemic, only as healthy as these healthy individuals within our community. Those folks go to the grocery store, they go to the hospital, they go to all these spaces, and so now offering the health equity was really creates danger for us as well. And so This project, this autopsy project, end of life project, came as a result of community members feeling as though much information around what actually happens after someone passes away. What is the process? Excruciating experiences and stories. People have shared this even began the project. Family members not hearing for so long just because there wasn't a system where they didn't feel as though the system was able communicate with them to receive the information that they needed. So this project, the autopsy project, took a move on. I started with some research, some basic research on what happens in the state of Vermont after someone passes away. What happens when it's a suspicious death? What happens when it's a suspicious death when someone has passed away from a long-term illness that we've written about? The reality is that procedural justice is what most community members are looking for. Most of the changes that we need aren't even necessarily changes. We just need to understand how the systems work. And so within this project, I provide education and teach folks how this process works. What happens if there's an autopsy necessary because of circumstances? What happens if somebody doesn't pass away versus, in any other circumstance? And what we've what we've learned so far from this project is that members are just looking for information. So it started with research has a policy which has an exemption for autopsies, for instance, and for religious reasons and cultural reasons. The reason why I'm helping on the idea of autopsies is because that is a very sensitive issue, and that is an issue that really came up for community members a lot. People don't know why I'm talking about this. And so not knowing why an autopsy would be necessary makes it really, really difficult to accept that your family member is going to have to go through something like an autopsy. But one of things that community members need at the end of life things, right? Some people need to wash the body within a certain way. Some people need to cleanse the body within a certain way. Some people want the body to be buried within a certain time frame. And sometimes our legal systems don't allow for that, right? If there's a suspicious death, again, it's not feasible for the body to be buried in 2 days. But as a Muslim and in Islam, that is the target. The label is that the human body will be buried within 2 days, right? And the reason for that is we honor the human body, either alive or dead, tremendously. And so even in this, it's important to us that we don't let human systems kind of huge. And so for folks, justice, even if it was a suspicious that justice in this world isn't really the justice that they're looking for. As a Muslim, then we say that our justice comes from God. And so even if it is a suspicious death, ideally people want their loved ones to be buried as soon as possible. And that's just one example. And so to go a little bit further into the project, we decided to go with some focus groups with 96 participants from a number of languages, Arabic, Swahili, Spanish, Somali, and Vietnamese. We convened these folks and we just asked them very simple and straightforward questions. What do you know about the system? What do you know about the system? What do you know about the system and the way it operates? And I will tell you, the first few sessions were really difficult. People showed very intense and deeply painful experiences, but they were absolutely necessary to hear. We also heard of some experiences, and some folks have showed some beautiful experiences. The reality was that there are a lot of very difficult stories to do from this project. And so we tried to have just each group within the first 2 sections we can only 25 people each. And so even the issue was of concern to community members. We tried to tell them as we were trying to limit even with the best efforts. It was really difficult to get as many as these folks groups did. And the point that I think about this is death and what happens at the end of life is very serious to community members. So what happens in this autopsy project? So we gathered out there 96 participants from the various languages that I just showed. Is to get even more feedback to engage with our governments and our system and to ask for what policies need to change in order for community members to feel as if or education needs to be provided for community members to feel as right steps are being taken. Mentioned idea of procedural justice. Procedural justice just means people need to feel as though the same process is being taken for them as would be anyone else. But when you put all the processes in, you feel like everything that's being done for you is not exactly the way it should be done. And so now it's the education that is necessary for community members. There's also some policy change that we can make. And so the culmination of this project as in terms of this outcome is to follow the community members who have shown some incredible concern. So the whole is to take them before analyze it, everybody figure out what it all means, and then prefer and some sort of policy change that is inclusive of all the community members versus by any of this project. And so it was the autopsy of the end of life project. It was a long project and first was community members and then back and telling them actually we can do some more changes, we can make some more changes that and so again to the point that I made in the beginning, the theory is the only people that know performance better as I can do this thing. And so this project is gonna be to because again I've been getting this because we tell them story and we should to move forward and so on. Next steps. Policy drafting coordination with WST and other partners. Those were presented to legislatures and ultimately moving on medical center first and then to our policymakers. And so that is what's next on our project. If you have any questions, please hold them to the end of the session. This project again was both exciting, saddening, and encouraging. I was really right in they showed a lot. I mean, some people were straight up saying, "Move your medical center, kill my husband, put the center, did this and that." And the government from that is even that opportunity to serve overseas hasn't necessarily presented itself, and now it seems like it is presenting itself. So I'm for ensuring that our community members' voices are being heard. So I put that aside as that. The next project I would love to share with you all about emergency room primary care and educational videos, which were done in partnership with the Vermont Justice Project. We're searching for funding for two of the videos. We did do the emergency room video. I was the actor, I'm a good actor. And you know, through the process coming in, there's a like, why the security guards acting? How long is the detention going to be done in the system? And you're sitting there for 4 hours. Emergency room, and you see other people come in and you see first, it seems like there isn't procedural justice, right? When you explain to people, hey, you know, anger is a lot different from a moving head, and you need to attend to the things that are more urgent and emergency. The meeting is all that is important. So this is things that are for community members feel that I'm actually a part of the community. When these things in support as I've been to the emergency room, I have to sit in there for hours. This ankle is as serious as somebody who is passed out. It makes it a lot easier for me to sit there and not feel so upset. So we are still looking for funding for the other two videos, but we're able to put together that emergency room video. And we had focus groups that we asked folks to reflect on how the viewers are to them, and a lot of people said there's basic information that they need that changes. First of all, the UVM microcenter, so people are just a little less thankful for us because they know what the systems are, but also people are feeling like they can be part of that, right? They can feel like, okay, I know why this is happening. And so we've got in there as well. The third project that I'm supposed to share with you is the multi-language council that we put together to push funding advisory council. And then colleague Vicky but I'd like to hear again just how strange the thought of this process was. Have maybe 6 or 7 departments, 5, 6, 7 departments that are involved in there, so just all kinds of skills within the Museum Medical Center to make this thing happen. As my friend Vicky over here always says, this council didn't exist before for a reason, and now it does. And that's all I'm going to say because I'm dealing with Meg. She's the expert on this, so I'm sure she'll share everything that I left out.
Don't ever call me an expert in anything.
I know.
Okay. My name is Vicky Mascareño Nelson. My pronouns are she, her, and I'm a patient experience partner at the University of Vermont Medical Center and the University of Vermont Children's Hospital. I work in, next slide, the Patient and Family Centered Care Program. So I'm not going to read that to you. So I want you to read that to yourself about what that means in terms of patient and family centered care. But what I want to talk to you about is I also want to tell you I'm in year 2. So he's year 1, I'm in year 2, and collectively we have learned so much together, right? We've learned a lot. So I am truly a partner, and Mohammed has been a partner since probably about 2 weeks after he got into the role. Because I needed a lot of partners to get this work moved forward. But going back to patient family centered care, I just want you to know that we have patients and families and caregivers or care partners who are volunteers. They volunteer their time to improve care experiences for all of our populations. We have 110 patient family advisors. There might be 1 or 2 in the room. Do you want to raise your hand? Yes. Okay. So yes, give a round of applause because they put in a lot of time. And they show up. Here's the thing is, they show up, okay? So Felicia shows up to do the work and be a partner. So multiply that times, a lot of other people. They do incredible work. So in my year 2, as I came in, is I realized there was opportunity for growth in terms of our patient-family-centered care structure. So that's the next slide. So what I want to talk to you about is a little bit of the structural components of patient-family-centered care. You can see that we had, when I came on board, there was a Children's Hospital Council, there was the Medical Center Council, the UVMMC Medical Center Council, a Transgender Youth Program Council for caregivers who have children who access the Transgender Youth Program at the University of Vermont Children's Hospital, and I saw opportunities for growth, and that's what we're going to talk to you about. So what I want to say about that is thinking about the Transgender Youth Program Council is a specialty council. So I want to talk to you a little bit about what that means in terms of the multilingual council. Specialty PFACs, or Patient Family Advisory Councils, are councils in which membership is defined by specific shared characteristics. They can be an intentional way to elevate issues that disproportionately affect certain populations and address gaps in healthcare. That's why we're all here, right? Specialty PFACs can provide intentional, safe spaces for advisors to discuss their shared experiences. Some of the advisors might feel more comfortable discussing issues and challenges with peers in an environment of a specialty PFAC. Specialty PFACs also provide flexibility to adopt policies and practices that work best for members of the communities involved. The room that I saw was that the system we provided in our councils wasn't a system that's built for all our communities. It just wasn't. And so one place based on the data and the research, which you all know because that's why you're here, and based on a lot of lived experiences, I really saw a need for creating a specialty council for people where English is not their primary language in terms of accessibility, in terms of health literacy. So that's where Mo comes in. So, and this also has to do with some collaboration. Oh, this is where Mo's going to say, Vicky, talk about your experience.
Talk about your experience.
Okay, hold on. That's so cute, right? That's what makes us good partners. Okay, so here's part of my story. Is I grew up in Cleveland, and I spent a lot of time in Phoenix as a kid. My mom is white. She grew up on a farm. My dad is Chicano, Mexicano, and he grew up in Arizona. They met at a bar in Cleveland. Good story, right? So here I am. Part of that story is I really grew up in seeing two different worlds. One in Midwest white Cleveland, and how my family accessed the world. And then I would go to Phoenix, and it was Spanish, and it was all very different culturally. And one of the things about it is that my dad is one of 14. He's the only one that went to college in his family. So he's the second youngest. He became the golden child. He became the person who had to help the rest of his family navigate the financial world, banking, and healthcare. And so I grew up, even though I was in Cleveland, for example, my grandmother or my abuela, she's in Phoenix, I saw my dad have to hold people's hands, or they called him Junior. They would call Junior, and they would ask him financial questions or health questions because he's the only one that had a college degree, and they trusted his ability to navigate those systems. My grandmother, like many others, in like Mexican grandmothers, she was very Catholic and very religious, and she was very superstitious. She trusted a curandera, which is a healer, more than she's going to trust her doctor. So there was a lot to get her care, and she trusted my dad to do that. So that's part of my lived experience, which is we're all here for the right reasons because the data says we should do this work, but I had lived experience to see what it looked like as it unfolded as I grew up. So here's where the collaboration comes in. So I find out that we're going to hire this position for the immigrant health coordinator. Mo was in for about 2 weeks, and I'm like, hello, excuse me, may I talk to you, please? Emailed finally, and also Kristen, thank you for introducing us and connecting us, because I knew that if this council was going to exist, I would need the right partners and the right innovators and the right disruptors and people with the positional power to make a difference. I worked in public education for 20 years, so I learned some things there too. I know that teamwork truly makes the dream work. So in calling out our team members who are in the room, this has been a really tight-knit group, which has been working for about a year together, and we've really pushed and pulled on this process. So here they are. First I want to say, see our little garden that we planted. So we planted a seed of an idea, and then we came together, and now we're like watering it and watching it grow. So these people are Chrissy Keating, Health Literacy Coordinator, and she's here. So thank you, Chrissy. Mohini Josie, she's here. She's also Language Access Coordinator. Yes, correct. Kathy Kelly is a social worker. She's not in the room right now, but she also helped. This has been a core team who's been supported also by Taylor Small and some other team members moving through. We, as a group, just to tell you, the partnership has been very, very important to move us forward. We had to push and pull on ourselves, on our biases, on what we thought this council should look like. And then we all collectively used our relationships with our community partners to move this forward. I had a certain relationship with different community partners. Mohammed and Mohini did as well in terms of interpreters and everybody she works with, and so did Kathy Kelly and Chrissy. So using our collective superpowers, we really kept coming. We would do our work and come back and plan and do our work and come back and plan together. So the collaboration to move this forward is one of the reasons why it exists. And I just can't tell you enough how lucky I feel to have found these partners, because this is what's going to help us with disparities. When we have people who bring their own lived experience and their own passion to disrupt the systems that keep doing the same thing over and over for the same people, this is the work we need to do. So I found like a like-minded team, and we've become really close over the year. In terms of community partners, really quickly, because some of them are in the room, Bridges to Health, ALV, Building Stronger Families Clinic, the Family Room, Vermont Language Justice Project, and is Jules here? Is Jules in the room? Jules, there's Jules. Jules is in the room. Jules is great at asking really challenging questions to challenge the process. And we really appreciate when Jules says things like, how is this going to be different than all the other surveys, all the other focus groups, and all the other things you've asked us to do before? That accountability is always super important. Thank you, Jules. So just really quickly, because we have to wrap it up, I want to talk to you about some hurdles. Money. There was no pipeline for this. In order to make projects like this work, in order to interrupt these disparities and reduce disparities, I just learned this morning, we have to be disruptive innovators. We have to take the financial pipelines that keep uplifting and amplifying the same systems into new systems that are going to reduce health disparities. So that's number one around finances. We also have a lot of discussions around barriers around childcare, transportation costs. How do we get stipends? We have them. Translation and interpretation considerations. And another thing happened here is patient family centered care program has been around since 2008. We have had our patient family advisors have had to fill out criminal background checks and abuse registry forms since they started. Can you all imagine the problems with that? You don't have a social security number, you can't be an advisor.
So we worked with Taylor Smalls here. Taylor helped us as well. We got rid of those. So when you come on board, you get a conversation, you fill something out, which we can certainly translate for you. Thank you, Lyson, and your team, of course. So we've reduced a lot of these barriers in order to make this work like this. So again, 1 year, 2 years, new system, new council. It can be done, but it takes a lot of partnerships and it takes a lot of innovation and creative thinking. So I guess the big things that takeaways I would say for you is just in terms of this is find the people that are going to help you grow, find the people that are going to make you laugh, and find the people that are going to push you and make sure these systems are going to do right by everyone, not just for the same populations we've been supporting for so long.
And if I can add, obviously, the way a supportive leadership team is it can't be overstated. The budget cuts and even elements made by Lana using 100% of our leadership team. So, to it, and I don't understand, we should get this new we need to make these things work. The top end of life project, it's 96 minutes of space, $15 a piece for sleeping. So we're asking for their expertise. We want to respect their expertise. This council that we're going to do, we've got childcare we've got to think about, we've got food we've got to think about. And so again, I just want to reiterate any leaders that in this space, if I can encourage you to be like those that are take a moment to realize just see things of supporting your staff. Sometimes it seems like a big bit that we're doing to in the end, it's that lives we change. So think about this council that we're living together. Some that we do is potentially saving us on in terms of lawsuits in the future. And so there's a lot of good education that we can offer to the that oftentimes these words about it. Some changes that can actually keep the system in a positive financial as well. So I really want to reiterate leadership, support, especially as we do this work. It takes a lot of money. The only way to get this work done is it is valuable and it is necessary.
Thank you. And you had one more slide.
Oh,
I just
yes.
want to briefly just
Hello. Just want very briefly, in partnership actually with the family room and maybe someone from the family room, we have put together a father's group. And this group is every third Saturday. We've got 2 facilitators, 7 fathers on. It's to discuss mental health and for African fathers. As an African myself, my family's in cases. My mental health, especially for men, is just like it is honestly in the States and elsewhere, is really not something that is discussed. And so this group aims to bring these folks together and get them to really understand them. That's mental health is and how important it is to just be on top of it and to understand how the everything is presenting itself to you. And so with that said, I'll hand it over to Stephen.
just barely, you just spit it out of my mouth. That's good for you. All right. I just want to say, you see such incredible work from Mohammed and from Vicky and this really team-based approach. I cannot speak more highly of the Community Health Improvement Group with Kristen Fontaine, Aaron Armstrong, Chrissy Keating, and so many others that really supported this work from the beginning when we brought this idea of building the Immigrant Health Initiative to them. They said, yes, let's do it. Marissa Coleman said, yes, let's do it. And it takes that type of leadership, like Mo mentioned, like Vicky mentioned, to really galvanize a movement. And it can be done, and we can push it to move a little faster than some of these situations and these systems generally like to move. So we just have to keep doing it together. But also, I just want to really, again, point to you two and your true commitment to community-engaged movements, community-engaged initiatives, really kind of pushing us at the healthcare system to do things the right way from the beginning. And I really cannot thank you both enough for the work that you're doing. So thank you so much. And so with that, I'm going to turn this over to Claire Baptiste. I'll let you introduce yourself, okay? But Claire is one of our phenomenal medical students who's in her second year. But the amount of work that she's been able to do in her first and second year is really, truly mind-blowing. And you'll see just what an impact she's really making on the community. We're so lucky to have her, so lucky to get to work alongside her. And with that, I will turn it over.
Thank you, Katie. That was a great introduction. So hi everyone. I feel like I see familiar faces from yesterday. So thank you for everyone who showed up yesterday for the first day of the summit. This session is kind of a continuation of talks earlier just now about sort of the importance of working and providing cultural responsive care when we enter the spaces that often are hidden in Vermont. When we think about Vermont, we think, it might be the whitest state in the US, but actually I too was surprised by the hidden diversity. So I want to introduce my panelists. I know Katie did it a little bit earlier, but we have Dr. Wells, Dr. Clemens. He is my Schweitzer academic mentor. He's a family medicine physician. Unfortunately, he couldn't make it today because he got scheduled into clinic, and I was like, oh no. But we have Naomi, who works really close to Ben, and we're going to all try to Ben wrote some comments to me earlier as well, so we're going to try to incorporate his voice today. And then I have Sarah over here who just popped in. Sarah works at the Family Room. She is the Family and Community Engagement Director. And so basically the Family Room supports immigrant families in Vermont, and she has a host of different opportunities that if students who would like to get involved in the Family Room, I have a QR code specifically with like the speaker bios. So feel free to scan that. That will be up throughout the entirety of this talk. So at any point, if you need to contact us later, feel free to hit that QR code. So I just kind of want to start off by describing how we're all sort of connected in the community. It's great that we cross paths, and I just want to mention that Naomi established a Bridges to Health program in Vermont, and so she utilizes a community healthcare worker model to serve immigrant and migrant communities across Vermont. And so with Naomi and I, she introduced me to the Schweitzer program, and we've been working with the Jamaican farm workers here in Vermont. And particularly we talked about sort of the community health needs assessment that was done in 2020 and what we could do to build off on that. And so that kind of introduced us to sort of the chronic diseases that primarily affect this population. Because when we think about the farm worker community, we have the migrant farm worker communities that primarily are dairy workers, maybe from Mexico or Guatemala. They're more younger than the Jamaican farm worker community. Jamaican farm worker community tends to be older men, and they might have a chronic comorbidities of hypertension or diabetes. And so I think the follow-up care that's required is slightly different. So that's how Naomi and I sort of work alongside each other to figure out what we can do given their challenging work schedules and how we can provide care in a rural setting. And then Sarah and I, we coordinated a health fair just earlier this spring, and that was we provided skin cancer checks, blood pressure and blood glucose screenings. We also did acute care services, and I talked about that a little bit yesterday, but we're currently working on sort of how we can provide other resources such as flu vaccines, and we'll be speaking about that. And then Dr. Wells and I, we met through LCOM, and we're trying to develop a training program so that students who are interested in working in the immigrant, uninsured, or vulnerable populations of Vermont can be trained, and then it will be kind of in time with the new clinic that's opening up in Burlington. So I just want to wrap up real quickly, just saying that we all find, the joy to support our community, but our goal today is really to encourage to get involved while recognizing that there are specific needs for these populations. And there might be some common concerns, whether you need to know a different language, or there's some legal accountability that you have to be worried about. Or you might just be unsure because, this seems like a huge time commitment, and how do I fit this into my schedule? So we're here today to dispel those myths and mental barriers. So I'm going to kick things off and just, throw a question over to Dr. Wells and the rest of his team. But first, Dr. Wells, if you could just share, what are some common mistakes or challenges you face when trying to deliver culturally humble care?
Um, it's a great question. So you said this mic's not. Okay. So one of the things that I just want to point out first and foremost that there are folks in this room who've been doing this work a lot longer than I have, and I think that's one of the first mistakes that we all make is that particularly coming from the healthcare community, we often think that we know how to do things and we know how we should tell the community what to do and what's evidence-based and what's not. And I think one of the things to realize is that most of the time, up until probably the last 10 to 15 years, what's evidence-based has been mostly built off of a model around a 70-kilogram white man. And I think when we talk about changing healthcare systems and we talk about changing evidence-based practice, we have to be more inclusive. And as Dr. Card mentioned this morning, talking about health equity data is one of the first pieces of that, and making sure that we have data that's accurate. And so I would say one of the biggest challenges and mistakes that we make is not sitting down with the community, not understanding what community organizations need before we start defining and or building projects. And I think that's why things aren't sustainable. That's why things don't work. We can all have great intentions and want to do things the right way. But if we're not including folks like Dr. Jules Wetchy, when we're reaching out to the community to understand what the community is saying they need and building it how they say they need it, then we're failing from the start. And so I think in terms of the biggest challenges, I think we have to learn from those experiences, those failures, really kind of fail forward, but really kind of start thinking about how do we do systems differently? And that's generally building those with a community-based, community-first approach.
Yeah, no, that's really good insight. And Naomi, you've been working out in the community for a while. So what are your experiences like? What can we learn from your experiences?
I'm going to start by saying it is freezing in here. So if anybody needs to stand up and like do jumping jacks in the back, feel free. I feel like we're just like directly under the cold. So I'm having a hard time thinking because I'm cold. So in terms, I feel like that question for me has brought up maybe two lessons that I've learned over time. And one, I think Mo maybe brought this up, but this idea of, not making assumptions based on someone having a shared culture or having a shared language or coming from a particular country of origin. I think it's really easy to consider this idea of cultural competence as something that you can attain, when in fact, it's not. It's not that simple, right? Everyone has kind of their intersections of identities and experiences and beliefs. So I think the one thing that I've really learned is instead of having an assumption that because I'm working with someone who maybe has some shared identities with someone I'd already worked with, not making those assumptions and instead taking what I'm learning over time, accumulating knowledge, and using that to inform how I'm asking the questions and the types of questions that I'm asking. So an example, as I was thinking about this, that came to mind was one of the first women that I worked with that I supported through accessing prenatal care and ultimately interpreted at the birth. She shared that she wanted me to find her a faja, and for me, my first interpretation of that was a belt. And I was like, a belt? Why does she need a belt for? So learning more and asking more questions, realized that, for her, it was really important to have kind of this kind of broad wrap that was stretchy to put around her waist as a way to recover from giving birth. And it was something that I didn't know about until working with this woman who was from southern Mexico. And the next birth was actually with another woman from southern Mexico who didn't want anything to do with a faja, right? So it wasn't particularly of interest to her or something that was a connection to her family. And so for me over time, really focusing on being able to then use that experience and ask, like, are there particular types of clothes or garments or things that you would use if you were back home leading up to a birth or after a birth? Or are there particular things that you would, feel like it would help you in terms of your recovery specific to things that you would eat. And then sometimes people are a little shyer, and so using those specific examples, but not expecting that their answer is going to be the same as the person that you worked with before, right? And then the second lesson that I've learned over time is really recognizing the value in how cultural beliefs or practices have value beyond maybe a medical outcome. I think sometimes when working with providers, I get the sense that there's this hyper focus on what the kind of scientific evidence has proven about that particular custom or that particular practice. And so what I've tried to do by kind of witnessing these interactions between patients and providers is to always ask the question of, is it harmful? Is that something that ultimately is going to be harmful to the patient health outcomes? And if not, can that be incorporated into the treatment plan? Because sometimes the example that came to mind this morning as I was thinking about this question was like putting vapor rub on your feet, right, to address a cold. Ultimately, I'm not a medical provider, so I defer to the medical providers in the room, but my understanding is that there isn't any, medical harm to doing that, and so that can be incorporated with also making sure that someone is taking their child's temperature and looking at respiratory rates and, what are the other signs and symptoms, so instead of kind of dismissing that idea, which maybe helps that mom who's far away from their family feel connected to their culture and feel connected to home, helping them feel like they're in a supportive environment instead of just kind of dismissing it because there's not a medically proven need for that response. So I think those are kind of the two things that came to mind for me.
Yeah, those are good points. And Sarah, you work with all people of all ages and families. Do you have any lessons that you want to share in regards to
yeah, thanks. First of all, I echo the things that you've both said. I'm not a medical provider, but I just those ideas. And I also want to say I'm sitting here kind of as a representative of the family room, and we do many things. I actually see a colleague of mine in the back, Manisha, who works in our clinic, which is connected to University Pediatrics. So I just want to say that because the clinic that Manisha works in is specifically for refugee and immigrant families. And it's a well child clinic, and the way they operate is that kids come in kind of on the same developmental basic age, like 6 months, something like that. So a number of families bring their children, and then they have their individual visits, but they also have a communal visit to talk about what's happening in a much more relaxed way. They sit on a mat on the floor and the kids are all playing around. And I think that model, just in terms of thinking about what works and what helps people feel more comfortable and at ease. And what happens then is that people bring things up that maybe they wouldn't have felt as comfortable to bring up with just an individual provider. But they're like, and other people are nodding, or, sometimes somebody's more extroverted and they bring up things that everybody would really like to know about. So I think thinking about that kind of model of collective care, and I know that's not really this question, but I just think that that's such a beautiful model, and helping people feel comfortable and connected. It also connects the parents with each other, and that's a big part of what the family room is about, is building community. And I think ultimately that is health also. If we feel connected, if we feel like we belong and know one another and know that we share difficulties, maybe they're not the same difficulties, but like, oh, yes, I know you suffer in a way that I relate to. I think those are all really important things. And then I'll say some specific things about, we've been doing these health fairs, and actually one thing is I learned from you, Naomi, is to think about what's the follow-up plan. We were enthusiastic and we wanted to do this health fair, which connected with some legal support and paperwork and all of these things. But there was a medical piece that we really weren't considering initially. And then realizing that actually Dr. Ben Clements came back to check on a couple of people had high blood pressure and, just those kind of things. So that practical yes, we want to do this. What are our follow-up plans? Another thing that I think is really important is accessibility. And, what does that look like? And one of the things I think that looks like is offering services at different times and different days. So the health fair we did in the evening, Naomi, and I'm also sitting here representing Jackie Reno, who's done a lot with our Spanish-speaking families, and she and Naomi wrote a grant, so we now have another staff person, Moira, who's working a lot with families. So and I asked Jackie I'll say that in a minute. But anyway, this idea of accessible times and places where people trust and have other good experiences. Today we were cooking for our family supper, and I asked a couple of the people who I was cutting vegetables with what's important. And one grandma said, what's important is people come with a lot of fear. And how can you help them feel comfortable and relaxed? And I think providing, however you do it, like how we're doing it, by doing it at the family room, it's a place where you come get food, where your kids can play, but I think there's a lot of ways to do that. I think Mohammed mentioned before the Saturday group, the Saturday evening group. We have a number of things that happen on weekends, and any kind of evening when people work so long and hard hours. So we have to really recognize that the 9 to 5 slot does not work for a lot of our families. So we do have to kind of go out of the way or reconfigure our schedules so they can work for families. And one last thing I was going to say, that Jackie, actually I talked to her about this too, and she said one of the things she feels like we all need to consider is the trauma that people have been through to get here, but not only that, the trauma that wherever they were leaving. And so there's a lot of big health concerns in the beginning. And how do we really look at that? And how do we there's a program, it's called Gentle Enhancement. How do we gently enhance things for families and meet them where they are and help them get to the next?
Okay, thank you, Sarah. And just to move things along, I just wanted to ask Kate. No, you're fine. I think we learned a lot about sort of the experience that these populations have when arriving to Vermont. Dr. Wells, if you could share if there are any legal concerns that you worry about when you deliver care with populations like these outside of the UVM health system.
Yeah, so I think this is a great question. So I think there's a lot of providers, and I don't mean just physicians. I'm looking at our nurses, our Ps, our NPs, techs, other folks in the room, pharmacists, that have an interest in working with immigrant, migrant, and refugee population. When we talk about taking care outside the hospital, our UVM Health Network, I can speak to that, self-insures. And so that policy, we have spoken with them. We have worked with those leaders. Erica Smart is our head of risk management for the network, and she has been a phenomenal advocate for making sure that medical malpractice insurance has been extended to all folks, whether they're working inside the confines of the hospital or not. And so we have documents, we have statements that ensure that you still have that insurance coverage, because with medical malpractice insurance, that's something we have to worry about as clinicians. And we've just recently too had UVM and the Health Network extend that benefit coverage to all nursing students and medical students as well. That's in partnership with the Vermont Islamic Center and their South Burlington Free Clinic that's opening up, of which we now have these medical malpractice insurances coverage for any person who is working with the UVM Health Network who wants to work with this clinic, and they are now covered. That includes our medical students and our nursing students, so we can actually get folks out to the community in spaces that are safe, hopefully with some referral patterns for many of our other colleagues. And then just to briefly kind of mention too, the UVM Health Network is working on a mobile clinic concept that we're hoping to also pilot to bring out to the parking lots of the Building Strong Families Clinic, get on farms, and take around our community to really get care out, to build trust. And so that is something that we are moving forward and pushing forward. We have some grants out there, but have also had some assurances from the network that they are going to support those initiatives. So that is coming down the pipeline to try to meet some of those needs.
Very exciting. And then also for providers who feel like there's a concern about time commitment or feeling underprepared, or how do I engage with a community that I'm not a part of, but I'm hoping to learn, what advice do you have there?
So I think, again, I think you have to really engage with your community partners because, I'll give an example. Dr. Ben Clemens is really amazing. I'm sorry he can't be here today, and has really been such a great resource for UVM Bridges to Health and many other folks with regards to the vaccine clinic. Helping to get that started during COVID resulted in thousands of vaccines for our immigrant migrant community really across the area. And, he was doing a lot of that on his spare time, not getting paid for that. And I think that's, not that any of us do this work to get paid for it, but when you're talking about a clinician, you're talking about in the middle of a pandemic, how to make those times work. It's tough. It is hard. But I think, and he mentioned and wrote some really beautiful, eloquent comments with regards to, some of this is really volunteer, but being able to be flexible with hours, being able to, go when the farm work is done in the evenings, be able to go on Sundays when, the work isn't as heavy, and trying to find ways that can meet the needs of the community. But I would say first, meeting with the community folks, building these relationships, understanding what they need. One of the things we were really trying to do with COVID was more medical screening exams on farms. And really what we realized is we didn't have the capacity to really do that. And I think that was a great learning lesson for me in our partnership. And you have a lot of good intentions. You want to do things as quickly as possible, but sometimes the systems just aren't quite ready. And so making sure that the systems are ready, making sure that these referral pathways are in place. And I think that's something that we're really working on as a health system and a network to try to figure that out. Historically, a lot of the immigrant, migrant, and patients have been seen by the community health centers of Burlington. And I really want to make sure that they are mentioned here because they have been really incredible community partners in the work that they have been doing outside the network. And we're working together to try to figure out how to build those partnerships between the network and the community health centers of Burlington as well. But I would be remiss if I didn't talk about just what a vital community partner they are in terms of seeing folks. So I would say, again, if people are wanting to get involved in this work, make sure that you're connecting with folks on the ground who have the long-standing experience in working with these communities to understand how not to cause harm. Make sure that you're not putting too much pressure on these systems that can't sustain it. And if you want to help support, also send your dollars, because there's no one that knows better how to spend money for these communities than the organizations that work directly with them. And so if you need to know who to go to, reach out to us. We can point you in that direction. But UVM Bridges to Health and Family Room, great partners. Send resources their way.
Yeah. Thank you. I just want to also echo something that Dr. Clemens wrote, was that these farm workers, they're hesitant to take time off during the weekday. So actually the time that they are available are evenings or weekends. And so feel free that if you have that time available over the weekend, if you're interested, scan the QR code. But I know since we have 5 minutes left, I want to make sure that if anyone in the audience has specific questions.
We have 15.
Oh, we have 15.
Yeah.
Okay, perfect. Okay. Well, now, Naomi, so I wanted to kind of talk more about that Bridges to Health program that you're involved in, and what barriers have you seen in sort of establishing trust with the farm workers or the migrant workers that might have recently arrived in Vermont?
So barriers to trust. So Katie, I think, mentioned one, and that is, and actually Sarah brought this up too, but really looking at, continuity of care and what ultimately is needed. I think Katie was referring to this clinic that we did in maybe 2021, Billy went out to a farm where we had previously offered vaccines, and we're going to do some health screenings. We'd previously done health screenings on farms with Latino workers, and generally out of 6 people, maybe 1 or 2 needed a referral to a clinic. They were able to get that referral within a week or 2. But during COVID and even now, access to primary care is really challenging. And so oftentimes that means 3 months, 4 months, 5 months before you could get in. And we had a situation where I think we screened 21 individuals and 15 had high blood pressure. And that was really, I think, an important moment, for us, one, recognizing kind of the difference in terms of the different communities that we were serving and the different needs that they have, as well as the challenges with the healthcare system. So it is hard to build trust when someone reaches out to you and they have a dental issue and you're seen as the person who can help them navigate on a foreign system. And you have to say there actually aren't resources right now. We literally have no where to send you. So that is one of our challenges within our team. And we have community health workers, a few of them are in the room, that are, working every day to navigate challenging systems. And it's really hard when there's shortages within the healthcare workforce, that it's not on our team, but it seems like, we're kind of the messenger. And so it seems like it's maybe that we're not wanting to help it, when in fact it's a capacity thing. Other barriers to building trust, lack of familiarity with the healthcare system. There's a lot of fear. There's fear about cost. There's a fear about missing work. There's a fear about, if the boss knows that I'm sick, particularly again with Jamaican workers, they have to be asked back every year. And so if they perceive that their health issue might be seen as a reason not to be asked back, they're reliant year after year on those funds. And so that will impact whether or not they'll seek out care. A lot of people we work with, particularly the new migrant and immigrant populations that are not on farms but are working a lot in the service industry, they're kind of in survival mode. So they really only have the capacity to take on what's in front of them. If they're offered a job for that day, they're going to take that job, which means they miss their appointment, which means they might not be able to be seen because sometimes it's 2 or 3 strikes and you're out. So really in that kind of navigating a lot of those issues in terms of the barriers. I don't know if you are going to ask about how do you get over that, but
How do you get over that? You know what I mean?
So part of it is having a diverse team that we work with. So everyone on our team is at least bilingual, with 1 trilingual member of our team. People have a lot of different identities and different experiences that they bring that we can rely on as a team to respond to needs. We really make sure that we can meet people where they're at, which for us means sometimes physically going to a space that is comfortable. Sometimes it's their home, sometimes it is the family room. But then also in terms of what are the needs that they're identifying. So addressing their needs first, centering their needs first, and then trying to figure out other opportunities that we know about that they might not know about. So we can offer we'll use health insurance as an example. Someone might come to us with a bill, and so their concern is how do I apply for financial assistance? And we can say, actually, your child's eligible for health insurance. Let's work on that. Or with transportation, we have some opportunities within the community to coordinate for transportation, but sometimes there aren't options, and so we make sure our staff is able to provide transportation as a last resort. So get out of this idea of brick and mortar and actually be physically in the community. What else do we do? It's really just kind of being adaptable, being consistent, and acknowledging when we can't help. That's probably one of the biggest things to maintaining trust, is being really clear. Sometimes it's easier just to be I ignore the message or not respond because there are limited resources and we don't always have some place to refer people. But it's really important for us to be able to say, I'm really sorry. I know that that's a stressful situation for you, and unfortunately that's not something we're able to help you with. If you have a health issue then, please come back to us and we'll help you navigate that. There's always more to say, but I think I have a last question for Sarah, maybe.
Well, I think, I mean, we're kind of right there at the time to kind of open up to questions, but I will say, Sarah, as far as what you have seen with regards to how to engage best with an organization like yours, um, if somebody is really wanting to get involved with the family room to support you all, what would you say might be the best way for them to engage?
Ooh, there's a lot of possibilities. Maybe I'll tell the story of Claire and Miran and Shania came and said we would like to do some kind of health fair. I think it was last fall. And it took a while. And actually, another med student had come a year or two before, and we hadn't been able to figure out. And finally, we realized we can't do it during the day if we want to engage with them. We have to do it in the evening. So that got clear. I don't know if this is fully answering, but and then we got involved with Bridges, and I think, and now we're a lot more involved with the Vermont Department of Health, which is really great. I did want to mention this. We just did a free dental workshop with the dentist John Englander from Southern Vermont, who's really Felicia came and helped. And he's really committed to doing something in every county during the year. And one of the things we learned from that, we need a lot more dental hygienists because they were who helped to provide the care. We thought we'd have 30 to 50 maybe, and we had 69 people who were seeing. We also realized we needed more Spanish interpreters. Many people filled in. So always learning. But there's a lot of ways we do have volunteer ways of getting involved with us, coming and if there's something that kind of workshop that you'd like to do or present or come along with us. So the next thing we're doing is with the health department and with Bridges and with Vermont Legal Aid, we're doing and with the learner class or many med students and also with another class from UVM and BED and Vermont Gas. This is one way we do it. We just say, okay, let's get everybody that people might need to see. And so if you're having to wait for that vision, which another thing we learned is people really need vision checks. What else could you do while you're waiting, and what would be valuable to you? And certainly paperwork. You all did a ton of paperwork. This this thing that we're going to do on October 30th, which we would love volunteers for, in all kinds of capacities to help families, to help kids, serve some food. We'll have some kind of light food for families. We're giving away coats. So there's a lot of ways we could really use help. Interpreters for sure. But I kind of lost track of what I was going to say. Something about that, but I lost track.
Well, I mean, the point you're making, though, I think, is that it really takes a collective. And I think it takes a collective of folks with a shared mission.
Yes.
And, one of the things that we're really kind of pushing for at the College of Medicine is sustainability. Really kind of culturally really led initiatives. And really trying to figure out how to get these programs coordinated, because a lot of folks want to work with a lot of communities, and there's a lot of people that don't talk to each other, and wasted resources, of which the resources are already such a scarcity. So how do we figure out systems of collaboration? And that's one of the big things that we're really thinking about the Health Network, and really thinking about the College of Medicine. So that I would love to open it up to folks to be able to ask questions. Share your stories. I think one of the things that's most important, particularly working with our immigrant, migrant, and refugee population, is really making sure we hear their stories and tell their stories when we can, not for them, but with them, and sort of supporting and making sure that their stories are out there and that they're told and their voices matter. And so in whatever ways we can support that visibility, that's really where a lot of the change happens. So that, please, any questions that you have? So Jules first, and then I saw Kathy.
Thank you so much. So my name and basically beautiful. You are let's have initiatives. So we're also seeing
What that works.
And they said, actually,
Can I give you this juice?
it's like,
So I was saying, my name is Jules Rucci. I am an executive director and founder of New American Public Health Initiatives because I'm public health expert and I have background in medical degree from Congo. So I know the team is a very, very good team. I know they are very open-minded. Sometimes I keep asking some difficult questions you cannot answer, but we have to do that because you need to advocate for the community. So one thing I will say that the social work is very important to immigrant and refugee communities. This is, I think, it's one problem now, right now, because we cannot take care of people just on hospital. And the test it's very, very bad. I'll tell you, there's one place I visited last weekend. It's like one it's a 10 families. They don't have place to cook. They don't know what to do. So we don't to say, I can't because I don't I can't to that. So that's kind of condition. Talking about equity, it should be everywhere. I think the hospital has to be able to identify today. Representative to the start, it's legal. Why cannot bring people that spend like 20 years and not be able in this kind of situation? As public expect if there's a kind of virus or a kind of epidemic, so all people they're gonna die. Because there's kind of promiscuity. We have advocacy to them. And also has to play a good role. I leave the team with the challenges because as now, it has to give to put women and work with organizations. We know our community members. We want to stay here, take care of them. It's kind of exclusion. We have many organizations. I can say thank you to Fanny the students for health fair. It's very important. Now, we have kind of a population who are illegal. They don't have insurance. They don't have access. What can we do? How we can collaborate to get this kind of population for health education, health promotion, and self-management of chronic disease. If you need us to speak loudly, we are ready because this is unacceptable. We have to give all opportunity to everyone. Equity is like if I live in a good house, even immigrants, they don't have high education, they don't speak English, they have to live in the same house like us, like Native American. We cannot not treat people, they come to hospital, give them education, the place they live. There's one toilet for 10 families. There's no agent. It's very, we have to change. Thank you.
Thank you, Dr. Wati.
Thank you, Jules.
Hi, I'm Dr. Mariani. I'm a family physician. I'm very excited about all of your work. I also work with AHEC, the Area Health Education, and we do a lot of collaboration with some of these programs. But I had one, maybe Katie, a question you might be able to answer is I worry about excluding our colleagues in Northern New York as part of the network and whether or not we have been able to kind of collaborate, or does New York do their own thing because they have different services? And then on a totally different note for Muhammad, we've got to talk. You want to know how your work and my work is connected, but as just a family physician, one of our jobs is 24 hours a day, we can get notified that we need to fill out a death certificate. And the barriers for the providers to get that job done, and everyone wants it done immediately, and the systems are not in place to make that piece of it, because nothing can happen until nothing can happen until the death certificate is signed, and it is a huge barrier for the providers to get it done. You would never think how difficult that could be such a difficult thing. But if somebody, it could get sent to somebody on vacation and sit in your in basket until the person covering for them notices it. I mean, it doesn't go smoothly.
So folks know that's a state that's not a network policy issue. That's a state policy issue. But yes, it is. Yeah, it's hard all the way around. I don't know, Mo, if you had any additional comments on that, or
Yeah, I think to have that conversation. We propose that we system internally here first, and then we come out and see what the state level anyway. So
yeah, some of it's our electronic system for sure. Yeah.
I would love to so we can really try to make that system a little easier. But if I'm not
I would say for the Northern New York, I think that's a great point. I think we're always trying to figure out from the network level, how do we be more inclusive across all sectors? That includes Southern Vermont. I think, one of the ways that we're trying to connect is through the community health worker program, both at the network level, but also with Katina Cummings' group, who's been doing phenomenal work in Southern Vermont, really building out a community health worker program. Naomi with UVM Bridges to Health has really built an incredible community health worker program, and that's a model of which, I'm hopeful that we all may start to adopt and find ways to co-fund and think about ways to do more of that type of work from our network side as well. Any other questions? I think we've got maybe time for one more.
I don't know if it's a question or a comment, but thank you for all the work. And I think that one of the issues is access to interpreter services. And I've received some requests where we can only serve, I'm from the network, and we can only serve the network partners, right? But at the same time, we acknowledge that if the work you do would be much more impacted by having qualified interpreters. So the access to interpreters is something that we need to think about, and we have to pick our battles, as you know. We've made some changes, but I think this is one very important topic that if you want to, talk about it as we move on and make sure that we can provide that service, it's really important. So I think that with language access, we are open to consider this and bring those to whoever we need to make sure that there is not only an interpreter, but not just the bilingual person, but somebody who's qualified to the job and help you save time and save resources too.
Yeah, that's a great point. Culturally contextual care cannot happen without adequate interpretation. And so I think that's a really, really important, valuable point. Well, I know you all may have many more questions. I do want to kind of just speak quickly to the moment that we're in right now. Many of these patient populations are under attack in many different spaces, and regardless of where you fall on the political spectrum, this is not a political speech. This is more of just advocate, get involved. You want to know where you can help? Again, tell the stories accurately, truthfully, of these amazing folks that come to our country for a different opportunity. And I think telling those stories with folks who work closely beside them, alongside them, and with them, that's the best way you can advocate. Get the word out that our immigrant, migrant, refugee population here in Vermont are doing incredible things in the state. Incredible things. And being able to tell those stories and showcase those organizations and really point back to the great work that's happening in this community is so, so valuable, because we have a richness here in Vermont that we would not have without these communities. And so really focusing on them and how to really build them into whatever projects that you're looking at and really bringing their voices to the table. And again, as mentioned in the last session we did, these folks also need to be compensated for their time. Please do not ask folks for their labor without compensation. If you're building budgets, if you're writing grants, if you're looking at how to fund something within your department or your organization, build in community consultation. It's vital, and we shouldn't ask folks to do things for free. this is something that we really should have been doing from the start and really thinking about when you're bringing that community first perspective in. Um, their experience and lived experience is valuable and should be treated as such. And so, thank you all for your time for this amazing group of folks. I really just, again, want to point to Claire for really kind of leading one subset of this and just as a medical student, really doing such great work. I see Javier Rincon, one of our fourth year medical students, who really was vital in getting a lot of the LCOM community collaboration with Naomi moving and off the ground. Mo and Vicky for their vital work at the network side of things. Sarah for your invaluable work that you're doing at the family room. Naomi, you have just really revolutionized the opportunities for folks in our migrant population, and this state would be lost without you and the work that you're doing. Kristen Fontaine, again, has really been such a huge champion from the Community Health Improvement Group, as has Erin Armstrong and Chrissy Keating. And this collaboration is such a wonderful, amazing thing to be a part of. And it's just been incredible to see it move. And without these folks, there's no way it would be moving the way that it is. So thank you all for coming, and thank you for your time.
You did it. Invitations for the I got invitations. Just here or come to the floor to like this is like nice. Yes. Timothy, I thought that yeah, thousand eight months. You know, that's England. Yeah, take clear some later as a champion. What is there like? What summer? Forget they are now over. Yeah, so I get into that. You know, like when we realize that, I'm very yeah, let's yeah, I was like that's the thing. But sorry, but I didn't care. We have to talk about this thing, right? Immunization. Good. So much here. Participants online. That's Sarah's dog, and there's a student. It's new. Okay, I'll see if I can make it. Should I let you to have this kind of evening first chance? Let's get it all done. We're looking to have first student. Family. So we get your yeah.